Let's get started. And the first thing that I want to do is just welcome everybody who has joined us for this this seminar or mini workshop on Edinburgh and the Global. I'm Steve Sturdy. I'm one of the co-directors of the Centre for Biomedicine, Self and Society here at the University of Edinburgh. And for those of you who don't know the centre, we are a Wellcome Trust funded, but also we have University of Edinburgh support and various other grants. We've been in operation for almost 4 years now when we first got our Wellcome Trust grant. And we're an interdisciplinary social science humanities research centre working especially on biomedicine. So we're a team of researchers, academics interested in particularly the sort of scientific technological end of medicine, biomedicine in particular. And our aim as a centre is really to try and exploit our interdisciplinary strengths. We've got a range of people from across the social sciences and humanities, so science and technology studies, scholars, historians, ethicists, socio-legal scholars, sociologists, anthropologists, all addressing these, what we see as really the big socio-technical transformations that are underway as with the rapid development of biomedicine. And our aim is to try and get away from our various disciplinary silos and to think about how we can actually bring these various descriptive, normative, analytical perspectives to bear on these big socio-technical transformations. The way that we've tried to articulate these interdisciplinary connections, including with scientists and medics, I should say, is to organise our work around a series of themes where we try to get beyond our disciplinary perspectives. So we have a number of beyond themes, beyond disease, beyond the body, and connected to this theme, beyond the global. So we have a number of theme members led by Breto, who is our dedicated research fellow on the Beyond Global theme, trying to think about how we get beyond conventional ways of thinking about global health and what our interdisciplinary perspectives can do. One key issue, and I'll just say this, I think, hopefully without preempting what Breto has to say, one key aspect of this, one perspective that we really are working to explore, is how to get beyond the idea that global health is so often presented from the perspective of the global north as something that happens elsewhere, something that happens in the global south. It's very easy to think of the north as simply an exporter of health technologies, of knowledge, of ways of thinking, of expertise from the global north to the global south. We are very keen to invert that, if you like, and think about where the global north fits in global health. It's something that I think has really been highlighted by COVID. It's very clear that the old ideas that addressing a global challenge like COVID is going to be achieved simply through exporting technologies from the global north, from the rich countries to the south, has very clearly been upended by the way that many countries outside the global north have dealt much better than Britain, the UK, Europe, with the global pandemic, with the COVID pandemic. So that is something that I think really has driven home to us. I think the importance of thinking about global health as something that the UK and especially Scotland is simply a part of, not a leading part of necessarily. And that's where this series of workshops has come from. Reiko's work on International Drug Control, I think situates that very nicely. This was Reiko's idea, was to use that as a perspective to look at Edinburgh in the perspective of global health. So I'll hand over now to Reiko to explain a bit more about what this workshop will be and where we're going with it. Breto.
Thank you, Steve. Thank you, everyone, and welcome to our mini workshop series, Scotland in the Global, HIV through Injecting Drugs and Beyond. As the Beyond Global postdoc, I wanted to organize this interdisciplinary workshop to bring together people I've interviewed, such as Ray, and people I've met, such as Alex in Shanghai, and all these great scholars. Because as I'm currently researching the global HIV through injecting drug use response, it really struck me that AIDS history is told separately from drugs history. So to this end, we felt Edinburgh's HIV experience would be a great topic to reflect on different epidemic responses. So we hope to have 2 papers, first by Ray, then by Alex, a little Q&A, followed by breakout discussions in smaller groups. We want to keep it friendly and informal and finish around 11:15 or 11:30 a.m. UK time. We do plan to produce a center webpage and a concept paper targeting the journal Social History of Alcohol and Drugs. So towards these outputs, we are recording this event. Please do keep that in mind. Can I also ask that you keep your mics and videos off to save bandwidth while the speakers are speaking? So today we'll have 2 speakers representing different perspectives, a former health practitioner and an academic historian. Our first guest, Dr. Ray Breto, was an infectious diseases specialist, and he was called back to the UK and Edinburgh in the early 1980s, and he was instrumental in the 1985 HIV through injecting drug use response in Edinburgh. Dr. Alex Mould is a policy historian from the London School of Hygiene and Tropical Medicine, and she looks at the concept of public in the British National Health Service, and she's also studied the tone of 1980s drug education campaigns in the UK. So, Ray, I will make you the host. Please take it away.
Okay, thanks very much. I'll see if I can work the technology. Now, share screen. How is that? I'm hoping that you can see a slide with the title and my name.
Yep.
Is that okay, Reiko?
Yes, thank you very much. It's working.
It's working. Great. That's fine. Hang on. I just need to minimize something else, which is here we go. First of all, good morning, and can I take the opportunity to thank the organisers for the invitation to take part in this seminar. I'm going to try and look at or give you some information about the HIV outbreak that occurred in Edinburgh. Before I do that, I thought I should give you my biases in a sense as a way of introduction. I'm a retired physician. I qualified in Edinburgh, trained in medicine and communicable diseases. Along the way, developed an interest in the immunological aspects of infection. Was appointed a consultant in 83, and by 85, I was involved in the care of patients with HIV. Including what is now called PWID, I think, or people who inject drugs. The key thing to notice is I had no formal training in addiction medicine at all. And for those of you not familiar with Edinburgh, I'll give you a brief outline of what happened. Essentially, there was an increase in injection drug use, mainly heroin in the late 70s and 80s, associated with a drop in marijuana and an increase in illicit non-pharmaceutical heroin. This slide simply was created by asking our patients the first year of injecting, and you can see here how it took off in 70, peaked in 83 and declined after that. We're not sure exactly why the decline. It might be ascertainment bias, but I think it's probably saturation of the marketplace. From the NHS point of view, This is what we saw as practitioners. IDU, injection drug use, associated morbidity, mostly overdoses, then skin infections to do with the actual injection sites, hepatitis B, pneumonia, and endocarditis. Unfortunately, the response for the healthcare system wasn't very helpful. The psychiatrists effectively removed themselves from the situation by ceasing to offer a service, and it just happened to coincide with, I think, with this epidemic. The legal system was equally unhelpful because there was this Misuse of Drugs Act, Section 9A, which criminalized the suppliers or supplying of injection equipment. The strategy was first employed, I think, with a volatile substance use outbreak, where they prosecuted the shopkeepers for selling bags and straws. And then a similar threats were directed against the suppliers of needles and syringes. So that by 1982, there was effectively no means, no legal means of purchasing equipment in Edinburgh. And there was also active removal by the police. Not surprisingly, this caused a dramatic increase in needle sharing, documented here by Roy Robertson and from his Muirhouse practice, and showing that at that time, Edinburgh sharing was occurring 3 times more often than in Glasgow, and with twice as many individuals, which pretty much sets the scene for the outbreak. The reason for the HIV outbreak occurring in Edinburgh lies in this, on the unexpected thing at the time we found, was that actually they were pretty mobile. The assumption was that everybody stayed in one place, but actually they went, as you can see from this, which is simply a diagrammatic representation of our patients, where they've been, which stretched as far as the USA and the Far East, but included a fair bit of Europe. The other key to our ability to map out the origins of the epidemic lay in the fact that all blood samples sent to virology were stored for 10 years. That occurred because there was a serious outbreak of Hep B in 1972 in Edinburgh, and therefore thereafter there were multiple samples sent for Hep B. And we were able to identify the seroconversion dates of most of our patients. And this is simply a plot of the year of infection versus the year of presentation. And you see this very tight infection band between 83 and 85. And by 86, there was very little infection going on. Remember, and that is when harm reduction comes in. And so something seemed to have happened dramatically before we were ever able to start harm reduction. And I think this is explained best by a brief dip into the biology of the situation. What we now know is that the viral load, sorry, I'm getting a message. What we now know is that the viral load, which is the level of HIV in the blood, has and determines infectivity, follows a U-shaped curve. Basically, it's highest at the end, at the start and the end. And I can show you that diagrammatically here with this red line, which shows the spike of virus in the blood. And by about 3 months, it's crashed and stays low for about 2 to 8 years, depending on the patient, before rising with the onset of symptoms. And when you apply that to the epidemiology, I think we now understand why this crashed post 85. The combination of intense sharing and the viral load explains the peak of infections. But what harm reduction did, which I think is not that I'm not saying harm reduction didn't do anything, what harm reduction did afterwards was to prevent what is, of course, everybody now knows of what's called second and subsequent waves of infection. So in other countries, what happened is, of course, the infection rate starts to rise as people get sick again. And so you get a continuous onslaught. But that didn't happen in Edinburgh. Briefly, most of you probably know this, that harm reduction came from Amsterdam and was essentially, let's avoid drug users being damaged while we wait for natural recovery. In Edinburgh, the first change was the McLennan report, which said, well, we better stop transmission by having needle exchanges. And the only problem with that was that it's illegal under the Misuse of Drugs Act. But interestingly, the Advocate General, they got round this by getting the Advocate General simply to issue a statement that they wouldn't prosecute registered doctors, provided they only exchanged 3 needles at the time. Roy Robert, the other aspect of harm reduction is opiate prescribing, and Roy was doing that in Muirhouse in 1982 with dihydrocodeine as a substitute for heroin. I became involved with methadone prescribing because we had patients admitted, and if you like, my patient zero for this is a patient who we had with endocarditis, which required 6 weeks of inpatient care with IV antibiotics, and the need to have lifetime abstinence from injection drug use so you don't get recurrences of bacterial endocarditis. So I was faced with the problem of the opiate addiction for the patient, the health and safety risk for the staff, trying to avoid people injecting into the IV lines because we needed to use antibiotics for that. And so I prescribed methadone as an inpatient. The problem arose what to do when you leave, when the patient leaves, who's going to take on it? Well, nobody else was going to take the prescribing on. So I read the guidelines, which at that time specifically said that any specialist treating a drug user should take on the responsibility of prescribing the drugs. And so I started to prescribe using what we call pink pads or HbA forms, which were basically outpatient prescriptions written in hospital that could be taken to an ordinary chemist. And if you haven't seen them, this is what they look like, or they did look like then. I also stuck very closely to the solution that they required, which was methadone DTF, which is very dilute and has a chloroform as an emetic to stop you injecting it. And if you've never seen it, that's what it looks like when you pour it out of the bottle. The next real change to methadone prescribing came in June '86 when Don Desjardins, presenting at the AIDS conference in Paris, revealed this very strong statistical association between the frequency of injecting and the loss of CD4 cells. So from that point of view, that seemed to be a game changer. And it presented us with this dilemma of having to stop people in-injecting to prolong their lives. Because if you could delay the transition from HIV to AIDS, which occurs more often when your CD4 count drops below 200, then you could obviously lengthen their lives. Remember that an AIDS diagnosis at that time, the average survival was 2 years and the maximum survival was 5 years. And most of these patients were in their 20s. So we started to prescribe methadone to outpatients, and it was really when we went through about 3 pads in 1 month that suddenly questions started to be asked, and there was lots of phone calls. But because they found the public health doctors couldn't disagree with the science or the guidelines, so they couldn't actually stop me from prescribing at that time. And you can see that it worked. Basically, we drastically reduced the amount of injections going on in our patients. So I think my take on what happened in the UK was that basically, this is not a great observation, was that change happens basically when society is very frightened. And the fear of HIV from people who inject drugs was a much greater motivator than any threat or damage to the patient who injected drugs. And that threat was, you could see that there are other examples that, for example, the threat of the sexually transmitted epidemic overcame a prime minister's opposition to widespread descriptions of sexual acts, of how you got it. The threat to the blood supply drove through testing and care development. And the key thing from what we're talking about today is that the threat of a PWID-related heterosexual HIV epidemic drove through a change at the ACDM in drug policy. Essentially, in '88, they recognized that the threat to HIV was a greater risk than the drugs. And John Strang and Jerry Symptoms viewed the fact that they said we were at a point of change, a point of crisis between the old ways and the new ones forced on us by HIV. And 90, John Simpson was talking about this and talking about harm minimization and the echo, and he said basically that it was just like the Safer Sex campaign. People weren't going to give up sex, so we had to encourage safe sex, and so the same thing had to be done for drug injectors. There was obviously a lot of resistance at that time, but I don't think that resistance has gone away. And I'll give you a brief example of what I consider to be modern day resistance to change in care for drug users. PrEP is pre-exposure prophylaxis, which is basically using antiretroviral drugs to stop people becoming infected. And there have been 15 studies, most of them double-blind, of sexual transmission. And if you take the pills, it has an 85% efficacy. And the only downside is you are likely to get other infections, such as condoms. There's only been one double-blind study of PrEP in HIV in drug users. And I'm not sure whether that's lack of interest or difficulty of organizing it. But it was done in Thailand, and from my point of view, it seems to did very well with a 49% reduction, which you could get up to 7.5% if you got good adherence, and they got that by using directly observed therapy. The patients were interested because 60% of them went on to enroll in the open label study, and it was associated with a significant decline in injecting behavior and high-risk sex. So the WHO recommended it in 2015, the CDC recommended it in 2013, and again in 2018. But in the UK, BEVA, which is the British HIV Association, decided not to recommend it. They suggested that it should only be, that because we should stick with current harm reduction programs, and that it should only be considered for people who couldn't get to needle exchanges or in outbreak situations. And if you cast your mind back to what happened in Edinburgh, I think that's going to be very difficult because of the timescales involved. By the time you've recognized an epidemic or an outbreak, most of the infection has spread. So although PrEP is available in the UK, it's not, as far as I know, being used for patients who inject drugs. And I think this is an added harm minimisation record that probably should be considered in Scotland, particularly perhaps in prisons where they've always struggled with harm reduction. It's not a magic bullet because it doesn't prevent Hep C. So, you know, but it is something. This simply lists the bits of opposition or resistance that I ran into in my time, and I think it might be a useful basis for discussion later on. Thanks very much. I will now stop my screen sharing, I think. Is that right, Raiko? And allow you to take over as host. Sorry, I'm still trying to...
Thank you for a fascinating paper. I've always found it really fascinating how your immunology expertise, it really helps you understand disease spread historically, but also epidemiologically. So I know I know everyone has questions, but let's move on to our next speaker, Alex, who I will make host, and then we'll have Q&A after. So Alex, please take it away.
Right, hopefully you can all see that. I'm going to take silences that you can.
Thank you.
Yeah, it's okay.
Yeah, good. Okay. Well, thank you very much. Thanks very much, Breto. Thanks very much, Steve. And thanks very much to Ray as well. It's really great to follow that. What I thought I would do, I guess, is zoom out a little bit, both in time and space, and a little bit in topic, and think just a bit about some of the anti-drug, specifically anti-heroin campaigning that was going on in both Scotland and in England, not exactly before HIV really started to take hold amongst injecting drug users, as we'll see that's part of the context, but before it started to kind of make its way into the health education messaging. So what I thought I would do is look at kind of two contemporaneous anti-heroin campaigns in both Scotland and in England in the mid-1980s. And as we'll see, they employed different tactics to try and dissuade young people from using heroin. And they were underpinned not only, I think, by differences in approaches to health education and drug use in particular, but also related to the place of publics in the local, national and global context. So what I do is begin with some brief background on drug education and patterns of heroin use in Scotland and England up until the 1980s, and Ray has really covered some of that really well, so we can maybe skip over that a bit more quickly. And then I want to focus in on two campaigns, the first of which is Heroin Screws You Up, which ran in England in 1985 to 1986. And the second is Choose Life Not Drugs, which ran in Scotland in 1985. And both, as we'll see, had a mixed reception. And this reception tells us something interesting about how different publics read and respond to health education messages. These readings need to be understood in context, and that means taking account of the local and national pictures. This then, I think, helps us think about how to place Scotland, England, and other high-income countries in relation to the global and to global health. So just a kind of bit of background really on drug education before the 1980s. For many years, health educators had argued that specific campaigns against drug use were of very little value and could potentially even do some damage. So the one that you can see on the slide from the 1960s is actually quite unusual. At this time, drug policymakers and health educators believed that drug education campaigns were unnecessary, or worse still, were potentially damaging. They were afraid of the risk of actually encouraging young people to use drugs, the so-called boomerang effect, so that the campaigns, the argument was, would raise awareness about drug use amongst people who didn't know about it before, and then they would start taking drugs. And there was actually some evidence from the US to suggest that this might actually have been the case. But in the 1980s, drug use, and especially heroin use, as Ray was telling us, began to increase at an apparently alarming rate. So if we look at the national picture, this is the graph you can see is notifications of heroin addiction to the Home Office from 1960 through to 1989. It seems to show kind of quite a significant increase in heroin use. So in 1977, there were 2,016 known heroin addicts. That's people who'd been notified to the Home Office. But by 1982, there were 4,371. So heroin use appeared to be increasing, but it also appeared to be spreading across the UK. So there had been a perception, I'm not sure how true this was, that it had largely been a London problem, but heroin use started to appear in regional cities, and of course, as we heard, particularly in Edinburgh. At the same time, political and media attention towards heroin use began to increase. I think there were signs of a sort of brewing moral panic. Drug users were thought to pose risks not only to their own health and well-being, but also to social and moral order. And of course, the situation was exacerbated still further when it started to become clear that HIV could be passed between IV drug users through shared needles. And again, you know, the kind of, as Ray was telling us, the sort of spur to sort of action and rethinking the relationship between HIV and injecting drug use and how we should deal with drug users really started to change following the work that was done in Edinburgh that indicated that a very high proportion, over half of injection drug users were HIV positive. And this helped increase the perception that heroin users were a risk not only to themselves, but also to society as a supposed vector for HIV transmission. But I want to take a step back and look at two campaigns against heroin use that were launched immediately prior to the period when the scale of HIV amongst injecting drug users was widely known. And I think this is important because it helped set the stage for how HIV and drug use were dealt with, but also I think tells us something broader about health education, drugs, publics, and how we understand and interpret their responses to drug education messages. So to start with Heroin Screws You Up then, well, the initiative for the campaign in England came from government ministers. The intention was to prevent further increases in the prevalence of drug misuse and ultimately to reduce its incidence, especially where heroin is concerned. And according to the health minister at the time, Ray Whitney, the aim was to influence and inform young people deemed to be most at risk. And the people that were defined at most at risk were young people who had either been in contact with other people who were using or experimenting with drugs. Now, this of course went against what health educators and drug experts were advising. Indeed, the Health Education Council, the body charged with health education material in England, had refused to run the campaign, or at least in the way that the government wanted them to. The Health Education Council wanted more time to develop materials and they wanted more resources. So instead, the government turned to the Central Office of Information, the government's official communications body. The Central Office of Information commissioned an ad agency, Yellowhammer, to develop the campaign, and it was designed by Sami Harari, who later went on to develop the very famous AIDS Tombstone campaign, which I'm sure many of you are familiar with. The Heroin Screws You Up campaign consisted of 2 short TV advertisements, a series of press and magazine ads, a poster, and a leaflet for parents. And it ran for just under a year, from April 1985 to March 1986. It cost £2 million. So what I thought we'd do is take a look at some of the advertisements in a bit more detail to look at some of the messages being communicated, the themes at work, and the publics being imagined. The magazine and newspaper ads were mostly black and white. This of course meant them cheaper to reproduce, but also the monotone colouring exaggerated the dark message of the ads and the apparent dangerousness of heroin. The ads featured a mixture of male and female protagonists, all were young and all were white. Each ad had a similar look, but a slightly different emphasis. So in this one, it appears to be primarily focusing on the physical and mental consequences of heroin use. So there's a picture of a young man. He's surrounded by details of the physical effects of injecting drug use and addiction to heroin. The text underneath elaborates on this and emphasizes how the side effects begin before addiction sets in. So what we've got here is a narrative of progressive decline from the use through to sickness and addiction. And it's all reinforced by this image of a pale, dirty, sweaty, spotty, very ill-looking man. Similar themes of loss of control and progressive decline were at work in this ad. It emphasises the apparent inevitability of addiction, even for those who are sure that they can handle it. The physical consequences and descent into sickness and possibly death, or at least feeling like it. And again, all of this is emphasised by the image of a gaunt, haunted-looking man. The images and presumably some of the advertisements were not just targeted at men, though. It seems that some were targeted specifically at women, and these were some of the ones that actually featured women in the advertisements, although some of the same themes were at work. So here again, we have progressive decline, with the woman literally moving across the image in terms of her decline. But it's not just about the physical consequences of heroin use. There's also emphasis on the mental cost of heroin, but also the financial cost and the cost it's going to have for your looks. Indeed, it seems to have been the case that there was a greater emphasis on appearance in the advertisements featuring and presumably targeted at young women. And I think it's particularly obvious in this ad with the tagline "Skincare by Heroin." It seems in sort of visually in some ways to be borrowing from cosmetic advertisements. But how are such materials received? Well, I think we can think about this in 2 dimensions. Firstly, the official evaluation of the campaign and its supposed impact, and secondly, how some members of the public reacted to the campaign. So let's start with the official evaluation. The campaign was evaluated by the Department of Health and Social Security by 2 commercial market research companies. One agency carried out a quantitative study. They surveyed 700 young people aged between 13 and 20, both before and after the campaign. And they found that 95% of respondents had heard of the campaign. Moreover, the survey suggested that there had been significant change before and after the campaign in relation to awareness about the health risks associated with heroin. Respondents also reported being less likely to take heroin if they were offered it by a friend after the campaign. However, the survey noted an increased belief that death was an inevitable consequence of heroin use. And obviously this was an erroneous belief, but it's perhaps not surprising given the tone of the campaign. A qualitative study based on focus groups and in-depth interviews dug more deeply into the attitudes, beliefs and behaviours of the target audience. It also found high levels of recall of the campaign and that the official message seems to have registered with people, especially with those thought to be at most at risk at using from heroin. Evaluators asserted that the campaign had fostered and reinforced negative attitudes and beliefs about heroin misuse across the sample. They also pointed to an apparent increased confidence amongst what the report called heroin rejectors by providing them with more information about the downsides of the drug. And the campaign's paymasters appeared to have been moderately happy with the results. Health Minister Whitney pointed to the high levels of recall and the suggestion that attitudes towards heroin were more cautious after the campaign. He asserted that although unrealistic claims for the effect of the campaign should not be made, the results he thought were encouraging. Yet the campaign came in for widespread criticism from those working in the drugs field, the wider media, and even in an internal DHSS review. The methods used in the evaluation of the campaign were questioned. A number of critics pointed to the small sample size and therefore the lack of confidence that one could put in their findings. And this mattered, especially in relation to the assertion that a change in attitudes had occurred after the campaign. But it was the campaign itself that provoked the most criticism. Some critics saw the tone of the campaign as making use of fear tactics to scare young people into not using drugs, something which could increase stigmatization around drugs and drug users, but also that such images would not be credible to those who were more familiar with drugs. Worse still, from a prevention standpoint, scare tactics might actually have encouraged young people to use drugs as an act of rebellion. Yet other critics pointed out that the campaigns were too broadly targeted. They were unlikely to achieve behaviour or attitude change, and that attitudes towards drugs were influenced by a range of other media and embedded within broader cultural and social structures and values. Indeed, when we think about the public response to the campaign more widely, there were signs that it did more than miss its mark. There were reports that young people deliberately appropriated the campaign and its imagery. And there were numerous reports that young people took the poster or the magazine ads and put them up on their bedroom walls. In 1989, Barry Sheeran, who was Labour MP at Huddersfield East, told the House of Commons that the rather effete young man in the heroin posters became a pin-up for some young girls. Health Minister David Mellor responded that it was an allegation that had never been proven, and it probably is hard to say whether this actually happened, but there have been enough reports, I think, to suggest that it probably did. And irrespective of the truth or otherwise, the campaign clearly did do nothing to reverse the upward trend in heroin use. Moreover, the imagery the campaign used was open to wider cultural appropriation or reappropriation. In the mid-1990s, a look became popular within the fashion world known as heroin chic. And according to that well-known authority Wikipedia, heroin chic was characterised by pale skin, dark circles underneath the eyes, very skinny body, dark red lipstick and angular bone structure. Models had emaciated features and were androgynous. And one of the key models supposedly perpetuating this look was Kate Moss. Now, I'm not saying that the Heroin Screws You Up campaign led to heroin chic. There are a whole host of other elements to this, but the similarity between the images, at least on the surface, speaks to the ways in which the imagery created for one purpose in one context is not owned by any one group or fit for any one purpose. Just as the Heroin Screws You Up campaign drew on stereotypical images of drug users to try and sell an anti-drug message, the fashion industry could use similar visual tactics to sell clothes and a particular body image. Heroin chic was criticised at the time and since for being tasteless and perpetuating unhealthy body images, but fashion being fashion, it actually supposedly came back into fashion again in 2013. And the ongoing kind of appropriation and reappropriation and use of these images has continued. Because when I was doing some research for this paper, I came across this sort of mocked up repurposing of a photo of Jeremy Corbyn, which was taken for the magazine GQ, to kind of reappropriate this and put it in this context of the Heroin Screws You Up campaign. So I think what we can say is that the Heroin Screws You Up campaign took on a life beyond that which its designers intended. A dark shock horror tone was open to ironic reappropriation. Now, I want now to turn to consider the Scottish health education campaigns, Scottish health education groups Choose Life Not Drugs campaign, which, as we'll see, was deliberately very different in tone, but ended up running into some of the same difficulties as Heroin Screws You Up. So although the Scottish health education group's 1984-85 campaign Choose Life Not Drugs was very different in tone, its public reception was also problematic. The Scottish health education group were instructed to mount an anti-drug use campaign by the Scottish Office, and although they were, like the Health Education Council in England, very reluctant to do so, they did agree to do it as long as it could be located within their existing work, which promoted positive health. The campaign, which cost £350,000, was launched in March 1985. Like Heroin Screws You Up, it consisted of TV advertisements and magazine and newspaper inserts. The tone and style of the material, however, was very different. The 4 TV advertisements were built around positive messages, including Be All You Can Be, Choose Life Not Drugs, and Just Say No. They were made in the style of a pop video and emphasised building young people's self-esteem. The Choose Life Not Drugs film was based on a decision-making model where individuals were confronted with situations where they might be encouraged to use drugs, such as peer group pressure, but the individuals chose to respond positively. The film promoted the notion that young people could make their own decisions despite socioeconomic constraints. And the magazine advertisements echoed the message about the ability to make positive choices. So the advertisement that you can see on the slide here was titled, "You've Got the Choice, Choose Life Not Drugs, Be All You Can Be." And it displays a photograph of a smiling youth on one side of the picture and 2 less happy young men on the other side. And the arrows sort of indicate, I think, the direction of travel between the two, that if you make the correct choices, you're going to be a lot happier. So the Scottish Health Education Group campaign material was an explicit rejection of the shock horror tactics deployed in Heroin Screws You Up. The difference in tone between the campaigns was not a reflection of the different health systems in England and Scotland, but rather a result of the fact that the health educators ran the Choose Life Not Drugs campaign, whereas the Heroin Screws You Up campaign was designed by a professional advertising agency at the behest of the Central Office of Information. Given the fact that the Choose Life campaign was designed by health educators, it's perhaps no surprise that it was received more warmly by health educators than the Heroin Screws You Up campaign. Choose Life was even praised at a World Conference on Health Education in 1985. Yet surveys of respondents point to some issues with the campaign's impact and interpretation. Awareness of the campaign was high. A survey conducted by the Advertising Research Unit at the University of Strathclyde found that 67% of 13 to 16-year-olds and 77% of 17 to 20-year-olds had heard of the campaign. Nearly all of the respondents felt that it promoted positive alternatives to drugs, but a third of those surveyed believed that the campaign treated the issue too lightheartedly. More significantly, a quarter of the sample thought that the campaign was out of touch with reality, and a quarter of working class and unemployed teenagers saw it as just a pretense. An especially problematic element was the framing of drug use as a choice. The Choose Life message was open to a range of different interpretations and readings, some of which ran counter to that which was originally intended. Indeed, the Choose Life slogan already had another set of connotations. Choose Life was emblazoned across numerous t-shirts throughout the 1980s. These were launched in 1983 by the fashion designer Catherine Hannett. She said that Choose Life was inspired by a Buddhist expression and was one of the number of political messages put on t-shirts by Hannett. But the Choose Life t-shirts were particularly popular, especially after they were worn by the pop group Wham! A more direct version of the Choose Life message in relation to drugs appeared a few years after the campaign. In the 1993 book and 1996 film Trainspotting, the central character, Mark Renton, a heroin user, delivers a soliloquy on the hollowness of choosing life and how he chose not to choose life, but chose heroin instead. Owen Welsh, the author of the book, deliberately inverted the Choose Life Not Drugs message of the 1985 campaign to say precisely the opposite. And in the 2017 film sequel, Trainspotting 2, Renton even says as much when a new character asks him what Choose Life means. He says, "Choose Life was a well-meaning slogan from a 1980s drug campaign, and we used to add things to it." Renton, of course, was not alone in choosing not to choose life. Indeed, large sections of the public appeared to be reluctant to make the healthy choices that they were being exhorted, encouraged, or cajoled towards. A key piece of research was conducted in South Wales in the mid-1980s. In an evaluation of a health promotion campaign intended to inform the public about the risks of developing heart disease, researchers found that beliefs about heart disease and risk were made up of a mixture of official messages interwoven with ideas derived from the mass media and the experiences of friends and family. Indeed, these were crucial to how people understood risk and thus how they responded to health education campaigns. The team noted that an aged and healthy friend, acquaintance or relative, an Uncle Norman, who has smoked heavily for years, eats a diet rich in cream cakes and chips and or drinks like a fish, is a real or imagined part of many social networks. A single Uncle Norman, it seems, may be worth an entire volume of medical statistics and several £million of official advertising. And, you know, Uncle Norman is a trope that people like to kind of trot out. Probably most of us know an Uncle Norman, but it's also something that the media love to kind of put forward, as you can see on the slide. But Uncle Norman's important because it combines with a degree of fatalism about the inevitability of sickness and death and allowed people to continue to behave in ways that they knew had negative health consequences. Some members of the public could resist health promotion messages when these did not chime with their lived experience or ran counter to other kinds of desires. If healthy living could be framed as a choice, then so was unhealthy living. Other research at the time and since has called into question the language of choice in such settings. Were unhealthy behaviours really choices? If so, what factors shaped them? Looking at why the public continued to make unhealthy choices exposed a range of reasons, both individual and structural. In a now classic study of young mothers who smoked, sociologist Hilary Graham found that for the women she spoke to, smoking was a way of coping with poverty and the demands of motherhood. Smoking, as was increasingly obvious by the 1980s, was strongly correlated with socioeconomic status, with the poorest in society most likely to smoke. Other kinds of negative health behaviours, from obesity to drug taking, often followed a similar pattern. And the reasons for this, of course, are very complex, but at the very least, I think they problematise the notion of choice. The ability to make choices is even further undermined in situations where there may be an element of dependence involved. The persistence of behaviour-related public health problems cannot simply be ascribed to individual choice. Such choices were shaped by factors beyond the control of the individual. And this wider framing of narratives around health and choice helps broaden the lens. And I want to conclude by coming back to the two campaigns and reflecting on what the differences, similarities, and what this can tell us. Now, clearly there were substantial differences between Heroin Screws You Up and the Choose Life Not Drugs campaigns. The tone was very different. Materials looked quite different, and they had a very different visual approach. They were making use of different tactics. So shock and horror versus a more softly positive health message. And partly this can be attributed to who was designing and running the campaigns and the context in which this took place. In England, the campaign was run by the Central Office of Information, as the Health Education Council had refused to run it. And one of the reasons for the dark shock horror approach, which the HEC was certainly not above using in other campaigns, but they probably wouldn't have used in this context as they knew too well the potential this had for blowback, as indeed was the case. In Scotland, the campaign was run by the Specialist Health Education Agency, the Scottish Health Education Group, and was therefore much more in line with the beliefs of health educators at the time. Indeed, the differences in the campaign speaks to wider differences over the purpose of health education and the philosophy that lay behind it. Should it be about scaring people into behaving or encouraging people to make positive health choices? And there was also a much wider debate that was going on at the time, and as we've seen with health education efforts more recently, particularly around COVID-19, about who or what health education or health promotion is for and how it should operate. Nonetheless, the mobilisation of the language of choice in the Scottish campaign could in itself be problematic. It was open to reinterpretation and appropriation, but also paralleled a broader shift towards a more neoliberal view of health that placed the responsibility for this on the shoulders of the individual. And this was a wider global development. But resistance was possible. As was the case with both campaigns, readings of these campaigns from some publics could invert or even subvert their message when it did not align with their values or experiences. And I think what this suggests is that in trying to situate the national and the local and the global, we also need to look at the ground level too. Thanks very much.
Thank you. Thank you, Alex, for a lovely paper. So we've had a wonderful mix of different frames applied to the same period of the 1980s, focusing on Scotland, but also the UK more broadly. So first, I'd like to thank our speakers for taking the time to present your research. We feel really privileged to have all these different frames. So shall we move to Q&A for about 10-15 minutes? Please feel free to just go ahead and speak, or if we get too many questions, we can also use the chat function.
Could I jump in and start? Just one thing that occurs to me about both the papers. I mean, we're thinking about Scotland and Edinburgh in the global. Both speakers drew attention, I think, to the importance of circulation in both the local HIV epidemic and the way that the kinds of responses that were made to it. And Ray was talking about there was that really very striking image of where people shared needles, and you showed people as far away as the USA. So Edinburgh users who were sharing needles in the USA and the Middle East. So I mean, it clearly, that really drives home, I think, the extent to which Edinburgh was not isolated in that respect. But I also wanted, there was a really interesting, I'm thinking about this from Alex's paper, the circulation of images and the way that images are themselves reused. I mean, there's some issue of reuse going on here, reuse of needles, reuse of images of advertising tropes. And especially on the sort of fashion industry, the way that the PR-oriented attempts to message against heroin use, the intersection with Catherine Hamnett and her Choose Life T-shirts, but also global supermodels like Kate Moss. I mean, it really does sort of bring home the extent to which Edinburgh is part of a system of global circulation that impinges on what happens here.
Well, in fact, one of the things that I left out or didn't mention was the fact that subsequent analysis of HIV isolates demonstrated that there is a connection between all the major cities in Europe who had HIV epidemics at the same time and Edinburgh. So Edinburgh is connected with Spain and with Italy and Germany. And so actually the movement of HIV pretty much did follow the movement of drug users. And that diagram I put up is actually, of course, is only also the people who returned to Edinburgh. So obviously anybody that left Edinburgh and didn't come back, I don't know about. They had to come back for us to get that bit of information.
Yeah, it's really interesting, isn't it? The question of circulation, and it operates at different levels and between kind of different categories. Can't think of a better word. So you've got you've got people and how they move. You've got how the disease and how drugs move. You've got how ideas move. You've got how images and representations move. There are so many different kind of levels, and they all mix and combine with one another. It's a really interesting kind of process of circulation, and I think it would be interesting to think about how those patterns move, and they don't just move north-south, but south-north and local to global and back again. It would be really interesting to think about how those different networks of circulation interact.
Can I come in on that one? Yes, is that all right? There's an anecdote that Richard Hartnell used to mention in the 80s about the very specifics of the Edinburgh epidemic, which I may be not remembering this absolutely correctly, but it was along those lines that there was a particular individual, I think an American, who came to Edinburgh and was very active in the scene and was HIV positive, and that there was a particular shooting gallery I think it was one particular one, but there may have been more than one in Edinburgh, where people congregated and shared needles. And that the other element in the story was the use of the police tactics. And on an occasion, the police raided this shooting gallery and closed it down. and spread the patterns of use and spread the groups around Edinburgh. So that peak which Ray described, there may have been a very specific little, circulation there, which had that element of responding to the way in which the police tactics, rather than containing the virus in a particular location, actually operated to spread it.
There were a number of myths about people would like to call patient zero in the Edinburgh epidemic. And the American was one of them. That may be entirely true, but actually from our data, it was an individual, or we identified at least one individual who went to Spain, was in Spain using drugs, came back, and he had the earliest known positive ever detected in Edinburgh, which is January '83. He came back and developed, and the reason we know about that is because he developed hepatitis B, went to his GP, had blood samples, and then went back to Spain after 6 months. And then in '87 came back again and was retested voluntarily and was found to be positive. So I say that I suspect it was much more likely to have been the Europe than the US. But I say they're all possible. Actually, interesting, Edinburgh was unusual in the term shooting gallery, because actually Edinburgh didn't have many shooting galleries initially. Everybody shot up in each other's houses. There was very good ITN video, newsreel at the time of this situation where they got in, and people think of sharing as often handing on the needle to somebody else to use at a different location. Actually, what happened was that people sit around a table, they communally prepare in the room, they suck up. And the other key bit of folklore or whatever about what happens or is taught is that when you shoot the heroin in, the other thing you do is you suck blood back into the syringe to wash out the last bit of heroin and shoot it back in again. So what you have is a blood-stained syringe. And in the middle of the table on this video, you see 2 glasses of water, one sucked up, flush out, another one flushed out. And it's that sort of collection of articles that spread the thing. The shooting gallery thing only came in with police activity, but by shooting gallery, essentially, because the people were being threatened with draconian sentences for, in inverted commas, possession of heroin, which actually meant they had a heroin contaminated syringe in their pocket. And people got things like 5 and 7 years sentences for that. And what, of course, the police did is they threatened people with that sentencing to get information about the dealers, and the dealers so they could break down the door. So then the dealers started insisting that people shoot up on the in their premises. So you couldn't leave with a bag of heroin. You had to shoot up, leave, and come back. And so the archetypal American shooting gallery, which used to occur, tends to occur in abandoned buildings and things like that, didn't happen in Edinburgh. Certainly early on, it only happened with as the lady said, with increased police activity, and we're probably after the spread of HIV.
Yeah, I mean, the stuff about patient zero is so interesting, isn't it? I mean, Rich Mackay's written a wonderful book about this recently, and about, it's a very problematic concept, and yet it's one, as we've seen with COVID, that we can't seem to get away with, because it seems like it's a story that people want to tell, and it's another story about circulation and where it comes from, and it's always somewhere else, and it's always someone else's fault. But also the kind of, nonetheless, we do still need to trace these stories back to the local and to the the differences of how epidemics responded to in different places. So I think, yeah, that's a really important aspect.
I was just wondering, So my sort of PhD is looking at some health education campaigns around HIV in Edinburgh as well, and just generally from the sort of things I tend to look at with, you know, the obviously AIDS Don't Die of Ignorance campaign and some of the more sort of localised campaigns around Edinburgh. In your sort of experience, have you found that there's quite a difference between the style of health education campaigns in England versus sort of Scotland? Because obviously you see that in the sort of heroin campaigns that Alex was presenting, but they're just in my sort of very limited experience. Obviously, there does seem to be quite a sort of difference. So I just wonder whether you could speak to that at all.
I mean, I haven't looked in detail at many of the Scottish campaigns, so I would be more than happy to take your word for it that there's a difference. And I think it depends. In this particular instance, I do think it was to some degree who was leading the campaign, and the campaign in England might have looked different if the Health Education Council had been running it as opposed to the Central Office of Information. That said, as I kind of hinted at, the Health Education Council weren't above using scare tactics and fear in other kinds of campaigns. So I don't know if I would necessarily say that there's a very clear distinction between England and Scotland. It might be to do with who's leading the campaign, what the issues are, and what the kind of the wider politics around the particular issue and how that's determined. But I'd be more than willing to take your word for it. If there's a distinctly Scottish style, that would be a really interesting thing to go in and look at.
If I could chip in, I became a GP in North Central Edinburgh in early 1983, and we were friendly with the Muirhouse docs, Roy Robertson and Kennedy Roberts and co, and got involved ultimately in education for GPs and nurses in the late 1980s. Interesting to look at the context. I struggle to remember what the patients were saying, but of course this was an era when David Player had been head of the Scottish Health Education group in Scotland, and then in 1982 became the same in England, the Health Education Council, for 5 years. And his main focus, David was a contemporary. My father died in November last year, aged 93. And he fell out with Margaret Thatcher around smoking. And the publication of The Health Divide in 1987 was the point where he fell out with his chair and he left for district medical officer work in Birmingham. In terms of the responses of professionals, I got involved in contributing a chapter to a publication in 1989 responding to the AIDS Challenge, which was a joint HEA and RCGP publication. And the interesting thing, taking chapters from around the UK, was that the different responses. Now, of course, in publishing a book, they clearly wanted to highlight the different successes or otherwise. So, for instance, in Bradford, it was achieving needle and syringe exchange in pharmacies. In Belfast, with precious little drug use, it was getting sex education into all schools, including Catholic schools. So a kind of parallel plus there. In Edinburgh, I suspect it was the development of a community drug problem service, mostly through the impetus of community psychiatrist Judy Greenwood, GPs, public health, George Bath, and so on. While I struggle to remember what my patients were saying, there was certainly different successes in terms of the response.
Sorry to jump in as the organizer, but Alex, is there a tension between the images and public health messaging being used so that substitution doesn't need to be the answer?
You mean in terms of treatment?
Yeah, so we don't have a consensus yet on whether we want to accept substitution as policy. So let's work on visually coaxing people to change their behaviors.
Yeah, possibly. And I think that if you're to be even more cynical, I think in a way, the primary audience, it was about being seen to do something and kind of respond to a moral panic and being seen to take action rather than kind of necessarily expecting that it's going to have a huge impact on actually reducing instances of heroin use. I would say the debate about treatment is somewhat going on in a separate sphere, I think. It's primarily about kind of looking like you're doing something and potentially trying to prevent drug use from escalating, but really not necessarily expecting that's going to have a huge difference. But you know, when you don't have many levers, health education is one you feel you can pull.
Yeah, I mean, if I can jump in, I mean, I was very struck by the extent to which running through many of these interventions, there's a real ambivalence about harm reduction of one sort, of any sort, because reducing harm, reducing risk only encourages bad behavior. And I think that's something that seems to have been seen, and it's not confined to drug use either. I mean, you know, there's all sorts of you know, the whole anti-birth control measures are often, you know, if you encourage safe sex, you'll only encourage more risky sex of one sort or another. I mean, that sort of trade-off, reducing risk only exacerbates other risks. And I was very struck by Ray's comment. I think it was Ray that actually it was probably there in both of you, that what seems to have tipped the balance towards harm reduction as a strategy was the concern with reducing risk to people who are not engaging in risky behaviors, to you know, heterosexual, non-drug using populations. So in a sense, the harm reduction becomes more about containment for defense of the protection of the normal population, if you like, rather than protecting those at risk. I mean, is that something that am I picking that up correctly from the two of you? Sorry, Ray, you're muted still.
All right. Okay. Sorry. I don't know why I seem to have been locked out. Absolutely. I think there were I said what struck me very much was that it's the protection of the whole society that affected change. I mean, before and after 88, I mean, the ACDM main thrust was the protection or preventing drug misuse moving outwards into the rest of society. And it was this sudden realization that, well, actually, you know, there are other things that we might get that are worse than that persuaded also a lot of people to change into worrying about HIV transmission as the key thing. And the problem is that whilst that was very good in one sense for changing policy, it is disease specific. It doesn't work all the time. And the best example of that is if you look at Hep C, which was discovered in '89, and that had there was very little change in drug policy as a consequence of the development of Hep C, which is actually more infectious than HIV, but it does not transmit to non-injectors very often. So sexual contacts are not at risk, and so shrug of the shoulders. Well, that's just up to the drug user. That's tough, isn't it? You know, I came across all sorts of, and I don't think it's necessarily policy that produces this schizophrenic view of drug users or drug use, which says, you know, anything that looks like it's rewarding them, we shouldn't do. That's a very bad thing to do. I mean, there are examples in Edinburgh on a Sunday. A vicar preached about the fact that he felt that what we should really do is we should set up a needle exchange in our church to help the people injecting out roundabout or whatever. We should start this needle exchange. On Monday morning, the public health doctor in Edinburgh got a phone call from a civil servant in the Scottish office telling him under no circumstances was that to happen. I mean, it was very specific, you know, and so that's not a dictate, a policy. That is somebody's prejudice in the sort of system being used to influence policy. And I you know, there was similar, I had another phone call from a doctor, or rather I met him at a dinner, in fact, telling me that under no rubbish, they do not inject in prisons. It just doesn't happen. It's all hyperbole, you know, it doesn't happen. And policy did not change in the Scottish office on that fact until a patient of ours was admitted from the prison to our unit and lost his leg because it injected into his right femoral artery. And then suddenly, oh, okay, now we'll have to accept the fact that it actually happens. And so this denial or this rewarding problem of we don't want to reward people, it runs through us all as individuals, and that actually influences policy. It isn't that somebody decides that we're going to have this policy of not rewarding. It just sort of influences. And I saw the same thing when I was reading about the PrEP. You know, they made this amazing criticism of the Thai study, saying the major criticism that Beaver made of the Thai study was that attendance had been falsely improved, if you like, as well, that because they offered reimbursement to people to attend DOT. So they paid them to turn up. And this was seen, and this would never be used in the real world. Ergo, it means the study is rubbish. And actual fact, what we ought to be doing is saying that's a very novel idea to how to get people to turn up. You know, maybe we should be utilizing something like that in Glasgow to get people turn up to needle exchanges, or maybe to turn up to take PrEP, which would seem to me to be a very good idea. So I think it's a sort of strange thing that runs through all of us. Rewarding bad behavior is a bad thing.
Thank you.
I have a question that's kind of thinking about how we think about harm reduction and what was happening that made people so uncomfortable with it in this time period. And I'm also thinking about the way that this affected health education. And I wonder about whether it's because part of it is imagining using harm reduction techniques or putting forward kind of harm reduction narratives to a young audience, because this is the 1980s and youth and childhood is just this amazing ideological football, and no one wants to say, here's how to have sex that's fun safely, here's how to take drugs which are fun safely, but especially when the target audience is youth, and the idea that you're going to allow that some people will have some kind of failed youth and have fun sex and get HIV or take drugs and get HIV it's almost like an impossibility. So you have to use scare tactics instead. You have to deny this kind of possibility because it's such an anathema to this kind of the ideology of youth and childhood, which is so much a kind of integral part of Thatcherism at this moment. I just wondered how that kind of all fits together, because you see it in the completely crap sex education that's taking place in schools across the United Kingdom. So I wonder whether there's also something like that taking place within drugs education and within the kind of impossibility of proper harm reduction.
Yeah, I think you're probably right. I think the problem with harm, the one thing that crops up in the harm reduction setup is the legal framework. And that's the difficulty, that you've got, you know, there are some things you can't do, but interestingly, and again, as I alluded to this, I mean, there's a great debate. I mean, as far as I can see, the big debate going on at the moment in drugs in in Scotland is saying, we would like to have safe injecting rooms, but it's the UK government that stops us. We can't do it because the UK government won't change the law. Now, that, and again, to me, that is a false, because I know that the Attorney General on the toss of it can just change it in a moment. He can just say, if it's run by a doctor, I'm not going to prosecute you. I mean, because they did it in '86. And so I think it's the same problem. Whenever you come up with a message or something of what to do, like harm reduction, we'd like to do this. There is this legal bit about because the Drugs Act is quite draconian, and I mean it's been changed a little bit. I mean it is now in statute that you can supply a needle and syringe, which it wasn't the case in '83. And I think supplying information about, and I know that it was quite difficult for them to get to set up a drug analysis system at festivals to try and prevent harm to people from taking drugs that they didn't know what was in them, and were they safe or not, or how much was in it. And they had to do a novel approach, say, okay, we'll set up this lab that will test the drugs, because the problem is that if you didn't watch it, you would be then accused of supplying the drugs back to the individual because you put it back. So that's, I think, the difficulty with it. It's more and more difficult than with sex, because most sex is legal in a sense these days, isn't it? Whereas with drugs, you still got the legal, and the fact that if the police choose to prosecute you, you are stuffed. And that I think is where, but you're right that we resort to scare tactics rather than saying, well, actually the sensible way you have to do this is this, you know, or don't do this. But as soon as you do that, you almost are on a tightrope. I mean, I know that I'm very, or I feel very confident in my view. If I had not stuck exactly to those guidelines issued by the ACADM about how to prescribe methadone, I would have been struck off. I mean, it happened in England. I mean, individuals who decided they would prescribe heroin or whatever in a different way, or do something different, or if you charged, of course, God forbid, if you were in the private sector, you would get struck off for prescribing. And I mean, we know that all our prescriptions were monitored by the Home Office, every one of them that was looked at by an inspector. And if you started doing something that was different, they would have been round and have struck us off. So I think it's the legal framework that goes around drugs that almost constrains the attitude. Plus, as I said earlier, the fact that there are a lot of people in the system, whether it's government or health, who have the same, we all have the same prejudices, which influences what we do. I think that's the problem.
I think that's really interesting, and I think you're absolutely right. The legal framework really helps determine how these things are shaped. And what's interesting is that there's also remarkable consistency. I totally take your point. There's particular politics of the 1980s and children and young people and how that's shaped and framed. But when you think about it, there's a remarkable amount of consistency around the ways in which drugs are dealt with and responded to. And that continues over time. There's still this legal framework, but it's underpinned by this kind of moral framework and not wanting to condone bad behavior and all these kinds of things that, yeah, the parameters of that have shifted a bit, but the underlying kind of moral condemnation hasn't gone away.
Again, in terms of the context, I think we were still scratching our heads about whether there was a soft drug to hard drug progression back in the 80s. And that debate went away, what, 10, 15, 20 years ago, because it was quite clear that the 11 and 12-year-olds started with cigarettes and then moved on to cannabis, and then somebody said, have a go at this.
I mean, the interesting thing about injecting drugs, though, is that as far as I'm aware, you don't teach yourself to inject. Somebody has to introduce you to it. and which is what you described, Philip, was exactly what happened in Edinburgh. People were smoking cannabis and were quite content with that, and then suddenly there was no cannabis, and they said, "Oh well, why don't you try this white stuff? It's pretty good, yeah." But interestingly, somebody still had to educate them on how to do it. And I guess maybe in terms of harm reduction, we should be trying to find those key educators in the drug system who obviously persuade people, or are able to persuade people to try this funny stuff, white powder that I'm going to stick in your arm, or I'm going to stick in your arm, because the first time it happens, always somebody injected them first, and then they were taught how to do it. So there are some key motivators in the system. It's just that we're never in contact with them.
Not to hijack the conversation, but by the, I think, mid-90s, DFID and UK aid is exporting its kind of harm reduction overseas in HIV programs. So I wonder if either of the speakers had any knowledge or ideas about how that becomes exportable if it's still being dealt with at home.
No, not. I mean, as always, I presume that. Saying one of the fascinating things I find is that for a lot, I mean, and I'm not saying I was probably the same, that for a long time, the success of harm reduction in Edinburgh, as in needles and prescribing, eventually was taken as, oh, what a great thing. Look, we stopped an HIV epidemic. And I think as always, in politics, you know, if it looks a success, then you can do something with it. Of course, what I was trying to show was actually it's not as simple as that, and that actually I'm not sure. Whilst I think that the harm reduction, the prescribing, I think substitute prescribing makes a difference to people with HIV. I mean, as in it makes a difference to their immunology. Let alone what else it does, but you know, it makes some difference. But needle exchange, you know, is quite good. But it didn't. What I was trying to show was it didn't actually make much difference to the outbreak. The outbreak happened and was on the way down. What it did was stop subsequent outbreaks. And I think one of the problems, or what I see as the problem, is that the success of using needles and syringes is almost stop the thinking, as I saw with Beaver. It stopped the thinking. Well, it works, so we don't have to do anything else. You know, there's only 3% of people getting it from needles, so that's okay. But I suspect that if it looks successful, then it certainly would have been exported. But as always, I've always felt that it depends on the context. I mean, you can't, as an example, substitute prescribing is not really going to work in Muslim countries. You know, yet when I was in Malaysia, there are plenty of people using drugs in Muslim countries. They're not recorded, or they're not counted. They're in prison usually, because when they get caught, you're thrown in the prison. So you do have to look at the cultural context very much, and I mean, I suspect that's what you have to do in terms of education programs as well.
Yeah, I'm afraid I don't know anything about the specifics on DFID and how this stuff gets exported, but I think the kind of broader point about where do these ideas come from and which examples are exported to different places and which countries borrow from each other is really interesting. You know, it's often talked about high harm reduction, Amsterdam, you know, those kinds of links, those kinds of circulation and networks. But it would be really interesting to think about which ideas don't travel as well and which stay more specific to those kind of local or national contexts.
There's no doubt that Edinburgh thought that they'd done it quite well, and I'm just looking at what was in sheet 39 of the local aid sheets, which started in the late 80s and drug trends in Lothian, drug users reduced injection from 88% in 1988 to 14% in 1993, thought to be due to health education messages and increased availability of oral substitutes. Simple message, perhaps simplistic.
No, I agree with it. I think it probably was correct to because it certainly pushed down. But of course, if you look at Scotland, the fascinating thing is it obviously wasn't that successful because we had at least 2 failures. One of them in '92 in Glenacle prison, where there was an outbreak of HIV which spread, which because of the policy not only spread around the rest of the estate, because of course people got moved from prison to prison or whatever, but also wives were infected because there was a denial process. And then prison actually is one of the major failures, I would say, of the system in Scotland, because they've really had a hard time grappling with what to do in prison. I mean, some of it I understood, and I did clinics in prison, so I'm aware of the concerns. I mean, prison officers were very concerned about the use of needle. You know, they said we can't have needle exchange because they'll be used as weapons. Now, interestingly, they have been established in other parts of Europe, and they haven't been used as weapons. So again, it's a sort of setup. And then the second one, of course, is the Glasgow outbreak in 2015, which has been attributed to homelessness and the use of stimulants. And of course, one of the big, we're talking here about substitute prescribing, and it was a great success, et cetera, et cetera. But it only works if you're addicted to sedatives like heroin. There isn't really an effective substitute for injecting cocaine. And the big problem about cocaine users or a lot of methamphetamine users is not so much is the fact that the injection frequency really goes up very high. So whereas a heroin user might inject twice, maybe 3 times a day, someone who's using methamphetamine or cocaine may inject 12, 20 times a day. That's how often they, and so you can see that when you look, well, and certainly I look at it in terms of the increase in, I mean, I thought three needles for the exchange was ludicrous when they brought it in, but you can see that for a stimulant user, 3 a day would be crazy. I mean, it would be nowhere near enough to stop sharing. But I say we've had these 2 notable failures in Scotland in 92 and 2015, with quite widespread. And again, in retrospect, they've managed to track down like 100 people, many of who didn't know they'd got it. So we shouldn't say, we've got to be very careful about saying, oh yeah, actually, we're exporting a success story here. We're exporting both a success and a failure. And we should look at the failures and try and see what we can do about improving the system in a sense.
Any final questions before? We didn't make it to the breakout discussions, but I think it was really nice to keep it flexible and have a kind of whole group discussion. So why don't we kind of wind it down? Just as a quick reminder, our next session is the 14th. We'll have an early modern historian and a contemporary historian who is actually here today. So please do consider attending that, again, from 10 to 11:15, 11:30. And we also have a third session for the 21st, where we'll have someone talk about the Scottish naloxone program, which is a world's first. So thank you to Ray and Alex for speaking today. It was a really great session. And I hope everyone has a nice rest of Wednesday and hope to see you next week. Thanks for coming. Bye.
Thanks very much.
Thanks.
Bye.
Thanks, Veronica.
So much.
Bye.
Bye now.